Joining. I want to thank everybody that's joining us today. If this is your first time joining us for these Innovation Grand Rounds, then welcome. I'm Steve Bopart, Executive Associate Dean and Chief Diversity Officer for Carle, Illinois College of Medicine. And these Innovation Grand Rounds are part of a series with the purpose of really building and bringing together a community of faculty, students, and staff, and researchers around this idea of medical innovation and really highlighting, showcasing role models in our community and elsewhere that give examples of this integration between technology and medicine. And so I couldn't think of any greater pair to present today to talk about just that, really this integration of engineering and technology and science with medicine. So it's really a pleasure today to introduce two speakers. And the first, Dr. Zimmerman, is a physician at Carle practicing sports medicine. He received his MD degree from the University of Wisconsin School of Medicine and Public Health. And he is also, as you may have caught us talking, he's team physician for the Division of Intercollegiate Athletics at UIUC, as well as Parkland College. So he's also joined then by Dr. Anderson. Dr. Anderson received his master's and doctoral degree in theoretical and applied mathematics from the University of Illinois at Urbana here. And he is researching the translational applications of MRI for neurological disease, focusing really on elastography of the brain and measuring neurological tissue properties. He currently is a Carle Foundation Hospital Beckman Institute postdoctoral fellow, so also just bringing together both Carle and the university around these various research projects and ideas. So please, I hope everyone can join us in welcoming our two speakers today, and we look forward to hearing about closing the concussion care gap and how this merger can really help address these medical problems. So between Dr. Zimmerman and Anderson, I'll turn it over to you then.
Well, first of all, thank you for inviting us, and we hope this is interesting and intriguing and get some thoughts shared and things along those as we go through today. One of the things I do want to say to all the members that are on today, if you have any questions while I'm speaking, please, you can put them in the chats or try to let us know. One of the confounding things of the weird football season is this went from being a home football game to an away football game. So when this talk's over, I gotta kind of get going and catch a plane to New Jersey. So anyway, so feel free to interrupt if there's questions as we're going along, and Aaron and I will do our best to answer these and hope we can spur some good discussion and ideas and where we're at with concussion care and science here at Carle and the University of Illinois. Okay, our goal today is we're really trying to shift the care of concussions from subjective oriented management to an objective management of concussion and diagnosis. One of the problems that we deal with every day in sports medicine and concussion management, it doesn't matter if it's just sports concussion, motor vehicle related concussion, is currently lots of our management ideas are based on subjective self-reported. This is based on symptom type, symptom severity. There's concerns with that of sometimes there can be secondary gain from having a concussion. Some people don't necessarily want to go to school. Wouldn't be bad to have a week off if we could get a week off. Some people, there's secondary gain from motor vehicle accident, liability insurance, things along those lines. And it puts the care provider in a very difficult situation when you're trying to differentiate that subjective, self-reported, don't have anything necessarily absolute to measure, and really trying to manage something that's severe and has long-term consequences. We're trying to switch this over to data-driven, normative data, validated data, that we can be able to compare this person the best we can to a age-matched, symptom-matched, medical history-matched situation. And so that's what our goal and what we're trying to do in concussion management here between the two of us and with our team at this point, which has continued to keep growing. Kind of letting you know where this all started from. is our sports medicine staff. Lots of the students, and we truly do enjoy this, come and rotate with us, and in your first and second years, getting some of those clinical competencies and getting exposed to patients in our office. And so some of you probably have been to our office and worked with us, and we do appreciate that. And thank you for those that actually have the ability to ask us questions and be intrigued with us. We really do appreciate that. So keep it up and thank you. But what is our Carle Sports Medicine program? And one of the strengths we have here when we're doing our research is the breadth and the depth and the amount of athletes we have access to. So our Carle Sports Medicine program, we have currently now we are up to 4 primary care fellowship trained non-surgical sports medicine staff. We have 2 sports medicine orthopedic surgeons. We have 3 advanced practice providers in our clinic. Our coverage, we cover all of the University of Illinois at Champaign's athletic department home events. We cover the traveling events that occur with football, as well as when our basketball teams travel to the Big Ten tournament or the NCAA tournament, we provide coverage for them as well. We also have specific clinics for the U of I athletes that were there 5 days a week in non-COVID related times. Now we're doing things a little bit different for this year, but still athletes come to our office on a daily basis here from the University of Illinois. We oversee the athletic trainers for the entire University of Illinois staff, as well as our high school employed athletic trainers. We cover, right now, we're at 22 high schools in the region. And so from a perspective of our strength and where we're covering across, it's a pretty wide area. We have 35 athletic trainers on staff at Carle here in our Orthopedic and Sports Medicine department. Work in a variety of areas. One of the things, we were just actually recognized by the Illinois Athletic Training Association for our job in promoting athletic trainers and getting them into clinics and giving them different opportunities and areas to work in the medical healthcare field. And I think at Carle, in this COVID pandemic, it's been amazing. If you've met some of them in our office, you could have ran into our athletic trainers everywhere from working security in the emergency department to helping clean the hospital. I mean, and so I get that they haven't been covering high schools, but boy, we have a pretty special group around here, and I'm very proud of them, what they do, and especially their knowledge and their work ethic. Our athletic trainers also provide rehabilitation for sports-related injuries. If you've been to our office, we have I think it's 5,000 square foot gym out there is what the size is, that we do our athletic training and rehabilitation out of. They also do our performance enhancement training, where individuals of all ages, not just high-level athletes, but we have a lot of patients that, boy, I just want to keep golfing, or I want to play tennis at a high level. How can I continue to keep playing as I get into my 60s, that come in and work with our athletic trainers, not to win the Masters or win a state championship. They just want to keep going and not hurting. And how do I do that? And so we have patients of all those age groups that work with us. Our athletic trainers work in our physicians' clinics. They're, if you've been here, they take history on new patients. They do exams on new patients. They're really kind of our right-hand people as a physician to keep our office going. And I think our patients really appreciate that. They also cover, like we said, the 23 area high schools, as well as Parkland and Danville. And so when we're not in a COVID situation where we're not having athletic sports go on, we have people pretty much every night covering events and seeing injuries and managing with all those things, and seeing these injuries happening real time as they come off the court or the field of play. Now, kind of moving on of seeing, okay, boy, we have all this access to these patients, these injuries, these things on this. Obviously, in our time frame, our concussions in my career, from when I started here at Carle in 2005, we were on the tip of the iceberg as we were moving forward. So since I've been here, we went from, boy, we think concussions are important to, yes, we know they're important. We found chronic traumatic encephalopathy. We've had the lawsuits settled by the NFL, by the NCAA. We've seen that, boy, these aren't just, ooh, I got my bell rung, I got to get back out there, to, wow, we've had a brain injury. Now, how do we best manage this for the people's long-term health outcomes and long-term livelihood and well-being? When we talk about our footprint, I think this is important. What I wanted to show in the world of how we can outreach is the diversity of the schools that we cover. As you can see in that map of those that are familiar with our area, you see the little bit of Urbana, the two red interstates are 57, 74, and then there's little Interstate 72 heading out of here. But we have schools that we cover a huge gamut of different diversity. We cover all of these schools in the Champaign-Urbana location, as well as schools that are outlying all the way down to Arthur, Arcola. Maybe students that are in the University of Illinois Medical School probably haven't even heard of some of those small towns. And so there is a difference in our diversity of the patients we see, their economic backgrounds. We have the ability of, a lot of my colleagues in sports medicine are happy if they have access to 2 or 3 high schools. We're very fortunate in our current setting and how we've continued to develop this program that was started by actually the head and president of Carle, Dr. Leonard, and taken over by Dr. Gertler and now by myself, that we really have driven this and are really invested in trying to do good athletic care to our schools in our region and our area. Medical students, yes, we'd be impressed if you could come and tell us which each one of these school mascots stands for. Sometimes at our Christmas party, we do this just to see how well we're doing. But it's kind of fun to see when you put this all together, you know, how many athletes we reach out to and touch their lives. And that's something we really want to continue to do is have them be as safe as possible, because we all know how important athletics are for developing young men and women into productive members of society and keeping them invested in the education process. Now that was my overview of things mostly. Now when we talk about current clinical standard of care for concussion management, I think there's things that we really have to talk about. And something that we've changed in this time frame of me being here is when we talk about concussion management, it's now to the point where it's almost regulated as much by law and legal issues as it is medical standard of care. There's medical liability if you don't follow the things that are mandated by law in the state of Illinois. For our collegiate athletes, there's mandates of how we manage concussions based on NCAA regulations. In professional, it's even one more step where they even have to have an independent physician that's not associated with the team be part of your care team. And so from my perspective, this stuff is really important as you get into medicine and clinical care, and it continues to develop and change because we're continuing to learn more and more about concussion. In our high school population, our clinical standard of care, we consider the good thing about our high schools is lots of our athletes are multi-sport athletes. And so in our schools, even including the Champaign-Urbana larger schools, many of our athletes participate in more than one sport in a clinical year. And we have, as a result of trying to modify what we can afford to do, what schools can afford to do, we pick our higher risk athletes that we get all baseline tests on. What those sports are at this point, we include football, boys and girls soccer, wrestling, and cheerleading as our high risk sports that we get baseline SCAT tests on everybody for. We consider these, if you look at the rate of concussions in their activity, there's a significant separation in those sports versus the other ones. Now, the lucky thing is a lot of our athletes do participate in football and basketball, so we have a baseline on them. And if the athletic trainers can, they even try to catch up on some of those other sports if they're out in the schools, things along those lines. What the baseline SCAT-5 test is a baseline balance and neuropsych test. It's paper and it's free. We'll go over that a little bit later here, so I'll answer that question. Post-injury, if it happens when an athletic trainer is present, they'll get SCAT-5 test post-injury once again. We'll be able to compare their pre and post test. Physician follow-ups are either through the athletic trainer or in the office in person, depending on how symptomatic the person is, what's their risk factors, and how long their symptoms last for, and have they had histories of concussions previously. Then once somebody is cleared after their concussion symptoms have resolved, there's a return to play protocol that we'll talk about later on. In our Illinois athletes, one of the things that we do in addition to that SCAT-5 is incoming athletes have an impact test that's done every year, which is a computer-based simple neuropsych test. And then they also do a BSI Index 18, which is kind of a baseline mental health history to kind of know where these people are at. And then follow up, we have a few more things that we can compare them to. One of the other things in collegiate and professional and high school is the coaches don't have a say in how fast an athlete comes back. And so that's something that's important to know. In the Big Ten and in professional sports, we do have athletic trainers that are independent spotters that watch the games as they go on, and they have direct contact and direct lines right to our radios on the sidelines to let us know, hey, you got to worry about player number 1 or player 5 or whatever. And that's been something that trying to make sure that, hey, even though we have a full team of athletic trainers and doctors on the sideline, let's just have one other person keeping an eye out for, what happened, or keeping an eye out for an athlete that we might have missed or trying to hide from. There is a question, and that question was, what recent changes in sports rules have been made to reduce risk for concussion? And there's been quite a few. And number one, risk, if you watch the game of football right now, those defenseless hits are now not only personal fouls, but they lead to direct ejections from the game. And from my perspective, those videos that you used to have of the NFL's greatest hits that I watched when I was a kid, and you watch guys get completely demolished. Luckily, we've made changes as a result of this, that almost every hit on those videos would now be an immediate ejection from the game. And probably one of the biggest changes is that. Number two is they've started enforcing when we talk about spearing or leading with your head. They put that rule into effect years ago to protect athletes' necks in football from a fractured neck and paralysis. But it's now a rule that they follow. If you hit or lead with the dome of your head or the top of your helmet in football, that is once again, an ejection and a 15-yard penalty. For quarterbacks, they've protected them more especially at the professional level. Any hit to the head, even with a hand, is now deemed a personal foul. The other side of things that they've done now in other sports is rule changes that allow the officials to stop the game at any point and say, I'm concerned about this athlete, and pull them off the field. This happens very frequently. I don't know how many of you have been to a high school game. Those high school officials are doing a fantastic job and not overreaching their power of saying, hey, I'm worried about player number 15. Can you have him evaluated by your athletic trainer? And they can't return back to the court until they're cleared by a medical professional. This happens in basketball as well. So if you fall, a kid hits his head hard on the floor or gets elbowed hard, the officials have the right now, and that's been a rule change to protect that the official can stop the game, mandate that person is evaluated by an athletic trainer or a medical professional before they're released back into into the competition. Now, if there's not a medical professional that's designated to be there, that's a concussion educated person, then that person is out of the game for the rest of the competition. So those are some of the easiest ones that, I mean, it seems like, boy, that makes perfect sense, but the power was not there for the officials to do that previously. And so those were huge steps that we could take that have been able to say, let's get this person evaluated immediately and make sure that this field of play or court is safe for everybody that's on.
And also the rules in the game, the football, the kickoff rules.
And so, and the other thing is the rules of the game, the kickoff rule, which you can call a fair catch. They're limiting how fast you can run, how far behind the kickoff line, so you don't get a running start on things. They've changed the whole setup for an onside kick of how many people can be on each side of the kicker as a football sports medicine physician, the play I hate and every time it comes up is an onside kick. Those of you that don't know football very well, it's where you try to kick the ball 10 yards and you try to get your guys to pick up the football before the other team does it, which usually involves somebody getting a free 10-yard full speed run at somebody before this happens. And so I'll admit, the more they can do to get rid of that play, the much more enjoyable football games will be for me. So unfortunately, at Illinois, we haven't been in too many close ones here yet this year to have an onside kick, but we're going to this weekend and we're going to win. So there we go. So, but moving on here, when we talk about our true management of concussions, we talk about this post-injury. What do we have initially? What do we do then after they become asymptomatic? Initial evaluation, if they've had, evaluate them right after the concussive injury. It's considered a concussion if they continue to have symptoms for more than 20 minutes after the injury is kind of that cutoff time scientifically and medically. Usually these athletes are then evaluated again the following day. If they continue to be symptomatic, obviously that's something that they talk with us about as a physician with. If they come in the following day, they're asymptomatic, they're able to pass their baseline test, everything that they do from balance to memory to recall is consistent with their pre-injury state, then they still go through a return to play progression. Always on a concussion, it doesn't matter if they have, I feel pretty good. We need them as athletes to come in and tell us, I'm back to 100% before we even do any of the testing. Then when we talk about the SCAT 5, and I'll show you what that involves later on here, we compare those to baseline, and they have to be at 90% of baseline. We give them a little bit of leeway, just test to test variation, so that we can say we're comparing them to them. The return to play progression after they become asymptomatic, past their post injury neurocognitive testing, whichever it may be. Day one, we have them do a 20-minute bike ride. We talk about it being low intensity. So it's something that, they maybe get a little sweat going, but they can talk in sentences to you the entire time. The goal of this is we're just trying to elevate their heart rate, elevate their blood pressure a little bit, see if symptoms come back. Day two, we do a 20-minute run, which is similar intensity, but this time we're now adding motion. So we're seeing, does that brain tolerate that elevated heart rate, elevated blood pressure, and moving in space. Day three, we let them do sport-specific workouts, a full cardiac workout. So in basketball, we'd let you do everything but scrimmaging. So you can run your 5-man weaves, do your layup drills, do your conditioning, do your lift, do everything. We're trying to really push that aerobic capacity to see if symptoms return. Day 4 is we let them practice. This is one that we get lots of parents upset about all the time, because if day 4 is a game day, everybody asks all the time, why can't my son play? Why can't my kid play? Because if you look at concussion rates, the rate of concussion that happens in competition is almost twice that of what happens in practice. And so we don't want to jump to that high risk activity without proving that they can handle that lower risk practice type activity. And day 5 is the paperwork day that we joke about. And what I mean by this is in our high school setting and in our college setting, most of these things happen in both. In the high school setting, in order for an athlete to return to play, they have to get through the first 4 days of that progression. Plus, the athletic trainer has to sign off on paperwork saying that they did it. The athletic director has to sign off saying that they did it. The student athlete has to sign off on saying that they did it. And a parent or guardian of that student athlete has to sign off and say that they've completed those tests. So as you can imagine, trying to get 4 signatures in a 24-hour period has been quite the struggle. The nice thing is, having done it appropriately, having the support of all the people in this area, you'd be amazed how well this happens and that it does get done. I don't think we've had a kid miss a game that was eligible more than 5 times because of not getting 4 signatures. And those of you that have done just trying to get people enrolled in studies know how hard getting a couple signatures are. So anyway, I think it's something that everybody's aware, and the education process has really worked. So when we talk about that SCAT test, so what SCAT stands for is a sports concussion assessment tool. And you heard that we talked about the SCAT 5. The joke in medicine to this day is we still don't know whatever happened to the SCAT 4. It kind of never got rolled out. So if you notice, we had the first SCAT in 2001. Then we had SCAT 2 in 2009, SCAT 3 in 2013. Then we jumped to SCAT 5 in 2017. This is pretty much a standard of care. If you said, boy, what is the standard evaluation? This is the set minimal. And so when we talk about this SCAT, it assesses symptom count, severity, memory, vestibular balance. And we're going to continue to go on here. I got a couple questions. Okay, great. There's a couple questions here on the chat that I'm going to get to. Is there a maximum number of concussions allowed? And I think they kind of all go together here a little bit. And then also there's the question about return to play after subsequent concussions, after it's not your initial one. Talking about the maximum number of concussions, I'm going to start with that one first. I'm adamant that there's not a set number, because once you say it's number 1, 2, 3, 5, 8, my answer is there's different situations that happen, and the more you're around sports, the more you see this. You need to see the difference between what kind of trauma it takes to induce the concussion. You need to evaluate how long it takes to resolve the concussion. You need to evaluate the time space in between the concussion. One of the things that people forget about quite frequently is in football that I'll see that makes me much more concerning is somebody will have a concussion at the end of their high school season in October or November, and it'll take them a couple of weeks to get better. And then bang, in the first week or 2 of fall camp the next year, they get another concussion. That's much more concerning to me than somebody that's had 4 concussions over a 7-year time frame. And so you really have to put in, and this is a little bit of art that we have right now, and talking about that concussion care gap, this is a little bit of art of really kind of balancing how severe their symptoms are, how long their symptoms last for, how long it takes them to recover, and then how much sport is in between each concussion, sport or trauma. And so on that one, there's not a set, this is absolutely the number. And you definitely have to have these talks, and they're long talks with patients and if they're under 18, their parents, about what kind of risk do we want to take? What is your risk level that you want to accept? What is your goal for your child in sports and what they're trying to do with it? Second question is, do we change the second concussion return to play? Once again, that's one of those things that we change and differ based on the space in between those concussions and how long their concussive symptoms last. So if somebody has a simple concussion as a freshman, and then 3 years later gets another concussion that resolves within a couple days, we would not change that return to play progression. If somebody has a concussion in the first game of the year, comes back after being out for a week and goes through the progression and then gets another concussion in week 8 of the year, that's something where we will change and lengthen that time that we go through that return to play progression. We also don't start that return to play progression quite as quickly. And once again, there's not a set, ooh, this is the mandate, this is the change. This is how we manage them here at Carle, and that's our set standard with them. So yes, we do change it if there's, they happen in the same season, they happen relatively quickly without much sport in between, those kind of things. We definitely adjust that. And then one other part about it is talk about multiple mini concussions. And in one of my things like that, and I guess I'll answer the first one, and I hope I don't offend you, is I'm going to say this. There's no such thing as a mini concussion. You either are concussed or you're not concussed. And so we can talk about there's minimal trauma that leads to a concussion. So you take multiple hits that are low impact, and eventually there's an additive effect that you get a concussive type injury. And then there's always the one that's easy for everybody to pick up, that athlete X, Y, or Z got absolutely chilly-walked. And then you can see that one and it's obvious. And so I think there is a difference between, maybe the term's not necessarily mini concussion. I would say it's more the concussions from repetitive low intensity impacts, not from the one big blow. Those concussions tend to take longer to recover. They tend to take longer to recover. They tend to have, their severity peak tends to not be quite as abrupt and sharp, but they tend to be where this brain's had multiple small impacts that led to injury. This is one of the things as we go further on here, we're going to talk a little bit about divers, and that's exactly why we have an interest in divers, is that multiple low impact expected head injuries leading to symptoms. So when we talk about the SCAT-5, kind of getting back to that, this is the form. It's a standard form. It's free for everybody. So the best part about the SCAT-5 is every major medical organization has accepted it as a method, and it's free. That doesn't happen very much in medicine. So our big red flags we worry about are big, huge, gross observations, right? If this athlete isn't waking up on the field, we don't stop and continue to do the SCAT-5. We go into, this is an emergency. We need 911. We need ambulance help. Let's keep them alive. Red flags as far as orientation to time and space. Lots of our athletes will be a little bit confused with that initially. They come out of it pretty quick. And so you got to understand when we talk about these red flags where we're saying, dude, it's following this athlete, adjusting them on the fly, continuing to reevaluate. Because the athlete that might need a whole bunch of red flags right away with that short-term loss of consciousness, in a couple minutes, he's doing okay. No, I don't necessarily need that ER visit and ambulance ride. So it's kind of you're looking for these things and you don't want to miss them. One of the biggest things that my concern always, anytime an athlete is knocked unconscious, you have to assume there's a spine injury until you can prove otherwise. And so don't ever forget that. That's why we're always poking on their necks, looking at things when they're unconscious, and keeping them in that neutral position until we know otherwise. When we get them off the field, one of the first things we'll do, you'll see our little medical tent. Hopefully you don't see it at Rutgers tomorrow, but we roll the old Carle medical tent over them, and what the heck is Zimmerman doing in there? Well, if you see me walk in there and you're like, ooh, I know, the first thing we're going to do is we go over a symptom score. And so as you can see on this, we have a standard set of questions, 22 symptoms. We have them score it from 0 to 6. We absolutely do that every time. And we get that score. I could show you a couple from a few of the last weeks to prove my point, but that breaks HIPAA. So what I'm getting at with this is we score these exactly like that so that we have a comparison, and then we track them on a daily basis. We want to see the reported symptoms decreasing as well as the severity decreasing. That's probably the most important thing of this first step, is it's a way objectively to monitor how they're saying they're feeling in these subjective feelings. The cognitive battery that we do with them then is where we talk about orientation to time and space. Sometimes that's hard as far as what time it is, because if you're with our university, when I'm out with the football team, heck, we get to the football field 2 hours before the game, and if it's in the third quarter, the guys, you'll see them doing the math, trying to add the hours together, because it's not like they have a watch on, or that they've looked at it in the last 3 or 4 hours. And so you got to understand that, where you're at in space, time, how long they've been in a competition or there. Memory words, what we talk about with this is where we give them a set of, as you can see there on the immediate memory, they talk about there's different 5 sets of words that we read to them. And we find out with them how well they can recall them immediately. And then we also do a delayed score back at the end of the test to see how many of those words they can recall. One of the things that we're really working on that we've noticed in our studies, and we'll talk later, is using the different lists, because bubble, apple, saddle, carpet, our guys know if you're not using the different lists. They memorize which ones they're supposed to know, and it's in their hard written memory, not their immediate memory like we're trying to test. We're also, where they're adding in the 10-word list, because guess what? We do have some smart athletes. We have a lot of really smart athletes, and it's fantastic. And so 5 words isn't, if they never are missing any, then we don't know how hard we're pushing them. And so they're starting, this is one of the adaptations they've added to push somebody's mental capacity and where they're at. We also do numbers, where we go through, those are right there where we're pointing, where you do sets of 3 numbers, sets of 4 numbers, sets of 5 numbers, sets of 6 numbers. We read the numbers to the athlete, then the athlete has to read them back to us backwards. And so that's being able to do that concentration, that they have to remember them, plus they have to be able to flip them back around and give them back to us, and you get scores for each of those. One of the things I'm kind of interested in is our athletes, and Aaron's going to laugh about this because I haven't even talked to him about it, is the months in reverse order. Our athletes are really getting smart at this now. And so they're actually practicing doing the months backwards, so it's in their hard written memory, so that they just know, okay, that's what I'm going to do: December, November, October, September, and then they go August. Anyway, you can see that they practice this. And so one of the things I would like to do in some of our testing, and Aaron's laughing at this, is what happens if we start giving them, they have to go backwards starting with a specific month, so that we can get a better concentration score on them that they haven't practiced exactly from December. Then we go on to vestibular and delayed recall. So vestibular, this is where we've added in the modified balanced air scoring system, or a BEST test, okay? This is a test that I think is an addition to the recent SCAT that's really been a game changer, where we've added in, and it's super, super important to have a baseline on this. And then not only have a baseline, but know how you did the baseline. So this balance test is something where they do 3 different skills for 30 seconds with their eyes closed. One is they stand with both feet together, hands on their hips, close their eyes for 30 seconds. Objectively, as the person performing the study, I'm watching for balance correction. So we do that with 2 feet standing together with their eyes closed, hands on their hips. Then we do a test for 30 seconds where we have them stand on their non-dominant leg. So if you kick a soccer ball normally with your right foot, you stand on your left foot, hands on your hips, focus on a spot on the wall, close your eyes for 30 seconds. We count the errors or how many times you have to correct. The third part of that balance test is we have you put your non-dominant leg in tandem with your dominant leg in front, with your hands on your hips, close your eyes, do that test for 30 seconds, count their correction. Then after we've done all these things, then we say, hey, can you tell me what those 5 words were that I asked you to remember? And it always amazes me how well our student athletes do it at all levels, because I think my ADD kicks in and I'm like, well, what number did I have to put a circle sometimes because I didn't pay attention enough myself. So it's impressive how in-depth these get in the difference in our scores. And then I'm always impressed with what our normal average score is, and that's something Aaron's going to talk about later in some of our studies. This is the part of the SCAT that we always have to remember. SCAT 5 tests don't diagnose a concussion. So this is just a clinical evaluation tool. It's up to the provider, the athletic trainer, or the physician to make that decision. So this can't be used by itself, and that's one of the reasons why it gets dangerous sometimes in concussions, because mom and dad want to use this stuff and then make the decision and diagnosis on their own. Concussion management, high touch, low tech. And I think this is an awesome part that we really strive for, is we have our athletic trainers in our schools so that they know our athletes. And this is super important because athletes want to play and they want to be successful. And even though we keep educating how important concussions are to take care of, they still want to play if it's that big game. And so it's super important to have this whole group that you see to the right here involved in understanding concussion management, education, and spotting this. Because it's one of my most important things at the University of Illinois that I was not part of this year because of COVID, is I spend the whole fall camp with them. And one of the reasons we do this is so that those athletes know me, but more important for me is I know them. So I know their little nuances of how they bop around the field, when they say hi to me, how they interact, how their eyes look at me, how they're, how in-depth, how gregarious are they, or are they kind of introverted? All these things play a point of, in order to pick up some of these small concussions, if somebody's trying to get away with something or trying to keep playing, and I shouldn't say get away, they're wanting to do what they love doing, is being able to know this person. Just like everybody says, well, I know my kid, right? Anybody that's on here that's a parent, you know your kid. And so having parents involved, that, especially at this high school level, of no, this isn't the way John acts. Or having a coach involved that goes, no, this isn't the way Sarah acts either. Something's up here. Super, super important. And you can't learn those skills. That's why it makes it so hard when I'm trying to manage the concussion in the office that I've never had contact with. And nobody that I know that knows concussions has had contact with. That makes it way more difficult. And so, because we're so subjective on these things. Our athletic trainers really try to get to know our athletes. Any of you in this talk, I'm sure if you have an athletic trainer, understand that relationship. Okay, there's a couple questions. So sorry, I'm jumping ship here. Are there smartphone apps that can get used to longitudinally track changes after a hit? Positional, gait, memory, recall, etc. So great question. There is an app that was used on the iPhone that they were trying to monitor with, where they were using the sensors within an iPhone to measure balance. And so they're continuing to develop those things. The problem with them is they get so sensitive, it's hard to pick up variation. And so people are working on that, especially for the balance kind of issue. The gait, memory recall, things like that. There's not an app necessarily to follow it because it's a SCAT 5 trademark issue. But all of our athletes have all of our athletic trainers have their SCAT 5 baselines that are available on the sidelines through our web service, and it's actually in our Epic medical system. So they can pull it up wherever they're at as long as they have internet access. And then another question, there's this gentleman that I know very well asked this one. Besides resting post-injury, would you suggest anything else for an athlete? Talking about head or neck cooling. And so my answer on that is what we're representing and what we're starting with is number one thing as far as recovery from a concussion, without a doubt, is first and foremost, limiting further contact or injury. So getting that athlete off the field of play and out of danger is number one most important thing for managing a concussion. Second thing from my perspective that has the most data is going with getting enough sleep and hydrating. Third thing, then we start talking about how do we control specific symptoms that they have. For headaches, to talk about cooling helmets. Cooling helmets work fantastic for headaches and things along those lines. It's all a matter of how severe, how do we get every person a cooling helmet? If their headache's limiting what they can do, yeah, we can use those. If Tylenol is working for their headache, we use Tylenol. If there's ibuprofen, there's lots of different options that you have, but you start treating symptoms as the physician. You don't necessarily treat the concussion. The other things that we'll talk about managing and taking care of is their mental health. We're talking about COVID fatigue and isolation. Think about if you're a high school athlete and you're watching your senior football season fade away because you're recovering from a concussion and you can't get back on the field. What does that do to your mental health, your well-being, your just how you look at yourself, your athlete self-identity? Now we're going to talk a little bit about some of the research that we're doing at this point. This is our running track actually in our facility of those that haven't been here. So if you ever want to come run a 40, or my son comes in here and pushes a sled of weights back and forth, and he makes me look like a wimp now. So it makes me feel terrible and old, but I guess I got to try. Concussion management, current research that we're working on here. We're part of the Big Ten Ivy League Traumatic Brain Injury Research Collaboration, where this is a collaboration between the Big Ten and the Ivy League of really trying to get an idea of exposure and injury, and trying to get more than anything, it's an epidemiology study of really trying to see what's happening in that setting. Our active studies are working on some that we have done, and then things that we're continuing to work on. We've done some significant accelerometer research. We did that at the high school level. We were the first ones to put accelerometers into a high school football team and measure their impacts. That was done all the way back in 2009 with Dr. Brolio and myself. More recently, we did a study and the question about the subconcussive hits from diving. We did a study on divers where we put accelerometers into their swim caps and measured the impact forces when they hit the water. And 1 week of subconcussive hits in diving practice and competition they had more hits in 1 week than an entire high school football season. So, and we started this study out of, we as a sports medicine staff working here, we were amazed at the number of concussions we were seeing in our divers. And that's what led to real world to translational looking at this. And that's the first study of its kind evaluating that. And we're trying to continue that study to get some more data at this point. That was a pilot study and working forward on it. We're also going to be co-investigators if this NIH R01 grant gets approved for point of care diagnostic testing, doing some blood biomarkers that the University of Kentucky has been working on, and a friend and colleague of mine asked if we'd be part of that care team. And so we're super excited and waiting for the NIH to approve that study, and maybe we can start moving forward with some point of care diagnostic blood work that can help us with that diagnosis of a concussion real time immediately. Why do we want to continue to improve diagnostics? These are the things that are happening and offered as far as diagnostic tests to help with. We talked about impact. Impact is a small computer-based format, takes about 20 minutes to complete. It's based on reaction time, verbal memory, written memory. Some of you have probably heard about this. It does cost money to run it. The biggest issue with all of these things on the improved diagnostic is that those first three up there are effort dependent. So if I want to sandbag, I can sandbag them. We talk about eye tracking and then imaging. High school concussions, this is what we were talking about with that accelerometers. This is what we did with Dr. Brolio. This is our working on one of the things that we talked about here. Unfortunately, we got off the ground with Dr. Brolio with our accelerometer research, and then this mighty school of maize and gold lured Dr. Brolio from Illinois to Michigan. Now he is the lead investigator of the Department of Defense $300+ million grant to evaluate concussion management and injury. And so this is something that's getting looked at from the Department of Defense all the way through the NCAA. This is eye tracking data that has just came out. And then I'm passing it off. I talk too long.
So as you can tell, Dr. Zimmerman is very passionate and has a lot of experience about concussion management. So when you get him talking, he keeps going. So we'll try and get through the next half-ish in the last few minutes here, and hopefully we'll wrap up and take as many questions. That's no worries. I think it provides the context as necessary because it is a complicated subject. People make it seem very simple, but it is far from simple. So since my focus is medical imaging mainly, I decided to take a little thing is we can go all the way to looking at CTs, but those tend to be breaks or bleeds. MRIs can be useful, but those tend to be more for your gross issues that are showing up large enough to be able to see by a radiologist. There is the new and exciting, the new 7 Tesla MRI, which is the highest field strength currently available clinically that we're getting installed as we speak at Carle. And you can tell the difference from what's currently available at 3T. As you move up into the far right one at 7T, you're seeing this actual damage that you can't see. And this is sort of the corollary between orthopedic injuries and brain injuries. Is usually brain injuries, you can't actually see the damage. So hopefully with the 7T, we'll be able to see some more of these things because it is actually optimized for things like brain injury where there's blood available. And it's the 7T is going to be able to pick those things up better. But what we'll run into is what is normal. So that's something we'll have to deal with moving forward. It's a great tool, but only used when we understand what it's telling us. And then another little aside here is that we are starting up a diving study, going back to one of the questions where someone said mini concussion. We think about that as subconcussive hits to the head. We're actually looking at taking a regular full study, looking at divers and a comprehensive understanding for a very understudied group, which will be coming soon. Okay, so the main thing that we talked about when we talk about having this full suite of 35 athletic trainers and all of these high schools and partners in direct contact is, if done well, which was done, they had the foresight early on, was to take that SCAT and use EPIC and put into what they're called smart phrases. And this is ideal for someone like me because you can take what would normally be clinical data that's always a mess, it's always a mess, and make it actually really useful really quickly, as quickly as it can be in this case, because everything is standardized form and it's actually available directly, which I can come back to. And so what this is saying, we have all of these SCAT data, they have baseline, post-injury, and this is at scale across all of these schools. And if you look in the literature, if you get the SCAT2, the leading paper of normative values, even at just 214 in adolescents. And then there was a follow-on to the SCAT3, that one was at the 758. But there's been no follow-on studies other than a couple small abstracts on SCAT5. But because of the clinical scale that you'll see here, we're actually able to look at multiple SCAT versions across multiple schools. We have multi-sport and at both SCAT 2, 3, and 5, and clinical practice, and looking actually at the clinical practice of implementing this has not been well understood. But, we don't always get to these extra things, this sort of extra, but we did have an intern. So that intern went back and we found boxes of SCATs from, certain athletic trainers' garages, because they knew this was so important that we had to have this and brought it in so that we do actually kid capture this. We're all up to speed now, so there's no excuse going forward. And what we're able to pull from that is 3,760 unique athletes. This is actually on the scale of the NCAA DOD with millions and millions of dollars to do. They do a lot more, of course, but at least for this case, we're capturing that many athletes. With that, we're having, of them, we have in total, over 3,000 SCAT5s. Of those without an injury, previous injury, baseline at least, we have over 3,000 of those. But we do have baselines with history of concussion or hospitalization. So our just first initial pass with this was just looking at SCAT5, since previously SCAT 2 and 3 have been done for normative values at least. First baseline ever, so they can have been repeating and practicing a lot about the words and the numbers and the months. And they don't have a history of brain injuries. We're trying to keep this as simple as possible. Even with that, we still have 1,719 of these baselines to work with across 18 schools, 6 sports, 13 to 19 years old in this high school. So included in that, within the SCAT, we have everything you see here, and we've already talked about. But with the pairing it with EPIC, we have race and ethnicity, so we can build a little bit more by having this connected to the EPIC system. There's probably other things, just kind of as far as we got. And if we think about this, things we can do are year-over-year changes. We can compare history of concussion or not, and we can look at baseline to post-injury. So what I didn't mention, we do have all the post-injury data, but here we're just going to focus on normative values, just to get a first pass. But a lot of these things are not normal distributions, so that's just a little point, a side point for the statistic people in the room virtually. A lot of these you're seeing on the right here, just an immediate memory score, you're seeing a lot of perfect scores and not a lot of distribution here. So that's something I want to go back and think about how actually different between groups there are. These are different in the bandwidth and U test for that comparison. Just to show here, we are capturing actually a pretty good representative because we're going across large schools, small schools, even within the area. We are capturing race and ethnicity actually pretty well, relative definitely to the local population, even nationally. We're well there, so we're not skewed too heavily in one direction or the other, which is good. We only have 6 sports here identified. A lot of them are unidentified, but we are capturing some differences there as we can see. Some of them aren't that big, on the order of 20 to 30. But. So we're flipped through, and a lot of this is, it's just a lot of charts, but I think we'll kind of find some of the things that there are differences that we can capture. So even between males and females, we can see that there are differences between symptom scores and the severity at baseline, and also their orientation score. But some of the other things are you're not necessarily seeing differences. For age differences, so this is your freshman, sophomore compared to your junior, seniors, and you do see symptom differences. You do see some concentration differences and delayed recall and balance, which you would kind of expect. As you get older, you should be able to be getting better at concentration and recall, and your balance should be improving. And we do actually capture that here. So these are kind of making sense that there should be differences between these groups. And then these self-reported, how many of them are saying I tend to have headaches, or I have a learning disability, ADD, ADHD, depression, because these are all relevant to how is that person going to handle neurological testing. Are they affected by this? And we do see across here, for the p-values with stars, we are seeing differences here. And especially the learning disability, ADD, ADHD, depression, is very useful when you're looking at groups when you don't have a baseline for them. So this is going to be helpful going forward. And we also compare, like, are people who have lots of just baseline symptoms seeing differences? We're seeing differences. Similarly with sport, we're seeing differences across there between that sport rest of the rest of the population. We're seeing differences across these. So you're not seeing these consistent results ever. And as I'll come back to, you're not seeing consistently differences. We have to pay attention. It really matters. We have to contextualize who each of these people are. So obviously clinical data, when done well, is fantastic. Even when it's done as best as possible, it's still not as clean as I would like, but hey, I'm demanding, I guess. But clinical practice is more forgiving than statistics. So as we talked about, there's a lot of nuance. When I pull statistics, I have to have a number. I can't just kind of, fill it in with my judgment. There are some limitations to SCAT. There's ceiling effects, which we talked about. We only have 5 words, and for baselines, we're trying to push through tens of people at a time. So it just adds a lot of work to do 10-word lists, I understand, but we have ceiling effects. 75% are getting a perfect score in orientation. That's not really that helpful. And then it's funny that the months backwards thing, I actually saw this as like, I can't believe a third of people can't do the months backwards. So I kind of had the opposite concern. But and also they're not being randomly chosen, which is unfortunate. So again, from a purely statistics perspective, that's not helpful. All right, so we'll skip ahead a little bit. And what I will say is that ideally this was not a chart review, so this made a big difference. This is the first clinically only SCAT-5 baseline data set that I'm aware of. It's the first multi-sport number comparisons for SCAT-5, and it's the first adolescent normative SCAT database of any version, have over 1,000 assessments, which is a very underserved population, unfortunately. And we're seeing these group-wise comparisons that that do actually matter what groups we're comparing. We do need to pay attention to these, exactly implement these in normative values. And then future directions, we have a lot more data to work with. We have a lot more comparisons we can do with history and repeated year-over-year changes and post-injury baselines. And we all have post-injury data that we haven't talked about. So, so basically the next phase is basically taking this that was worked in sports medicine, and now it's being pushed out across Carle. So starting out now is the Carle Comprehensive Concussion Clinic, or 4C. And this is actually taking that sports medicine idea and now applying to the whole population. So this is going to broaden its reach. It's very multidisciplinary. It's going to have a whole another suite of people involved, and it's going to think about both clinical and research from the beginning. And there's going to be this clinical care that's already part of it, but it's being formalized outside of sports medicine. And yeah, so we're just recreating this. I'm going to kind of skip ahead since we're running out of time. And so some of these things, big theme this year is there are a lot of challenges. There's no definitive diagnosis that we talked about or assessment test currently available. It has to be highly subjective, a lot of effort. It's effort dependent. Mental health concerns, comorbidities, and just limited time and resources for some of these assessments. We use SCAT for free, but we were afforded the opportunity to large-scale coordinated things when you do it properly, and that this progress of clinical data can inform research. We, can enable a research study which can then go back and improve clinical care is really a big deal. So I would say this is a big shout out to all of the concussion team, both on the clinical side and on the research side, that made this possible. So with that, I'd be happy to take any further questions. And I think there was a couple.
There are a couple in the chat there, but thank you so much, Dr. Anderson. And also many thanks to Dr. Zimmerman. I know he had to leave to catch a flight, but we'll definitely share our appreciation to him as well. Yeah, there was a couple questions in the chat. One had to do with more the helmet development, and if you can comment any on the changes or the engineering of these helmet designs to prevent lacerations or concussions from that standpoint.
Yeah, so with the Big Ten Ivy League concussion conference that we had in person last year, we had a spokesperson from the NFL that came. and they actually talked about how they are formalizing the whole process of what helmets are approved. They have to go through specific approval processes. And they've actually started to say, we believe in these ones specifically related to concussions and TBIs, and that they're not allowing helmets that don't pass what they feel is appropriate. And so I think you're seeing a big shift towards determining what where the priorities are with related to helmets, at least in football. Mm-hmm. So I think that's a big improvement. And they're actually, I think that's going out through with the NCAA, at least in the Power 5 schools as well.
Mm-hmm. I guess along those lines too, there was a lot of mention of accelerometers, but what other sort of sensors are important in these systems to capture and characterize the hit? I know there's multiple accelerometers, but are there others that are integrated there?
Yeah, so what I think is kind of interesting with the advent of video processing has gotten so much better at the NFL level as well, because they have the resources for this, is they have so many cameras within the field that they're actually, when they have spotters, they actually can look up film as well. And they've actually done all sorts of analysis where they're actually taking just two moving bodies in a video and they're recreating the dynamics that you would get from an accelerometer. So even if you don't have them, and they're recreating the direction that he had that was traveling, how they interacted afterwards. So they're not having to necessarily have accelerometers or other things on the athlete to still get a lot of information about what happens if you want to get.
Yeah, it seems like you could almost put the sensors on every player and then track back those types of interactions and contact. Mm-hmm. Yeah, very cool. I think it was actually me who put in another question about the coup versus contra coup injury, and I heard that the contra coup is actually worse. The site of injury, at that location was worse than the initial impact site. Can you comment on that, or?
Yeah, I have seen this as well. I'm not remembering offhand why that was the case, but I think this is the part that, at least outside of people who will pay attention to this, are surprised by the most, is that you think of just going to be in one spot, it kind of fits in one area and you're kind of over. And but the other thing is that we just think about, when I show those two pictures of it moving forward and backwards, and Steve, you're very familiar with this, the waves that are actually traveling, they're actually throughout the brain. So there is interaction throughout the brain. I can't quite speak to the specifics on the contra coup, but I think it's because partly the orientation of where that actually comes back, I think, matters. But.
Yeah. Very cool. Other questions from the audience?
I have a lot more questions. I'm just curious on your baseline study. I did a lot of work with Sam Browd and Stan Herring at the University of Washington and Seattle Children's Hospital on this, and was very familiar with the Lystead law. So this is like a super area of interest for me. Can you tell me a little bit about whether you're planning on doing a longitudinal study of these same athletes that you've been tracking, or is this going to just be sort of a short period of time? Because I think it'd be really interesting to track them over, 10 years, 15 years, something like that.
Yeah, so the closest, because it's all clinical data, this isn't actually a prospective study. We actually have, and maybe I flashed through just because I was trying to get to the end to get the questions, is we have a number of repeats of the baseline and concussion, so we have their history, at least while they're an athlete at Carle. We don't have any sort of follow-up that we've prospectively looked to try and track them over time. We've talked about some of these things, but it's one of those resources and just formalizing the whole process, because we haven't even gotten to this point yet. So, but I think it is a question of outcomes longer in life, because you're going to have those immediate health concerns right away, but are there long-term effects? For sure.
And would the 7T be useful in tracking those changes if you were able to do something along those lines, a longer longitudinal study?
Yeah, so again, this is back to a resource thing, because one thing I think I skipped over too is well, I sort of said that what's normal at 17. So ideally, you know, baseline, it would go, you know, if we could get every or some subset of athletes, say, coming into their freshman year, and then we could follow them over a seat, like over their career as a high school athlete, and then coming later, you get sort of an idea. The concern is always, though, what's normal. And so what we are doing initially with the 7T is doing a population study to try and capture some of those what is normal. We're going to have groups of people at different age levels so that we'll have some idea of actually teasing out the difference between those two. The 7T will afford much higher resolution. So if we are seeing subtle changes year over year, or you know, however many years it would be, we might be able to actually see some of these things. A lot of what people say about MRI is you have an image, you have something, but what's meaningful, even for well-controlled studies. So you would at least be able to get closer to the region that in a neurological region, what is meaningfully different, I think. So.
Thanks.
And also feel free to reach out if you want to talk more. If you have to talk.
I would love to talk to you about what resources you might need. I'm the development person, so.
Oh, yeah, okay. There you go.
Definitely want to talk to Jessica. You know, earlier in our Grand Round series, we heard from Professor Brad Sutton, and he was working, of course, with Graham Huseman about looking at stiffness changes in the brain detected by MRE. And I'm curious if you've used those algorithms on any of these concussion subjects to see are there mechanical changes in the brain tissue after concussion?
So the only one that we have right now is the diver study, but our colleague Curtis Johnson, who was here and moved to University of Delaware, he did actually prospectively look at hockey athletes, men and women, and he had 4 time points, so preseason, mid-season, end of season, and then it was a month or two following the end of the season. It was a recovery period. And you did actually see changes throughout the season, that there was a progression throughout the season in changing in stiffness or damping ratio, depending what metric really. And then so there was a decrease in damping ratio, and then that recovery period, there was a slight bump up. So I think that was the first one that I'm aware of that was longitudinal, at least over a season at least, looking at those structural changes. So it is sensitive to the subconcussive hits, because I think in that case, I don't think they had concussions observed. It was only subconcussive.
Very interesting.
I had a quick question. Good job, Aaron. This is Kevin Jackson. How's it going?
Yeah.
You talk about the women. I'm happy that you're doing women's sports, because I think that gets overlooked awful lot when we talk about concussion. We always look at male sports. Thinking about the women and the diving, and thinking about cheerleaders, and do you ever think about the time of their cycle that can have an effect on their brain as far as what you're seeing, either from MRI or other diagnostic tests that you're doing for concussions?
Yeah, so actually it's, I didn't know that, or you hit on something we actually are actively looking at. So we have a grant out right now. We have a pilot data set where we controlled for, this is why we're even willing to actually go do this in divers, for female divers, because we took a handful of women who are naturally cycling, and we did 4 time points across their cycle. And preliminarily, because this was a small thing, we did actually see changes in the hippocampus with MRE and with some of the memory measures we have that are hippocampal dependent. And we controlled for hormones. So we'll do all of that same thing in the divers as well. So we'll be able to control for the menstrual cycle while we're looking for that subconcussive change, because there's a huge animal literature that actually shows that the menstrual cycle, or lack of menstrual cycle, if you're looking at postmenopausal rats and mice, does actually change the brain. So yeah, it's a confounder, but hopefully we're at least controlling for as much as we can.
Good job. Well, nice to see you still doing these things.
Yep. Guess another question, speaker.
Yeah, I don't know if you can comment on that question or point in the chat.
Yes. Yeah, and I think we've talked a little bit in the past, Jesse, and we can definitely chat more. And we've seen your work and some of the other people who've done some of these simulations, which I think are very interesting, because it's surprising the wave dynamics of a concussion are much more complicated than we appreciate when you just think about that CT image where I showed just the whole brain kind of shifting back and forth and thinking it's just kind of a rigid blob effectively. There's a lot more going on there.
Mm-hmm. Mm-hmm. Very good. Other questions, either in the chat or just unmute and ask. I think this is really fascinating work, and I hope our audience and community realize kind of just how significant this is, the work that you and Dr. Zimmerman and the whole team are doing. I think even on the national level, right, there's just seminal advances coming out here, and I think being close to the Big Ten athletics here and having access to these athletes and all the way from the multiple schools to our university, I think it's an incredible resource for us to investigate. So we're very glad that you're doing this, and we look forward to the results that are going to come out of this. I think they really will dictate some policies and rules going forward.
Yeah, thank you for the opportunity, and happy to field any other questions as they come. Or Jerrad and I are both available once a week. Well, Jerrad obviously left, but we're as available as we can be, and we're happy to engage. So thanks again.
Wonderful. Well, thanks everyone for your questions. Thank you again, Dr. Anderson, and pass on our regards to Dr. Zimmerman. Thank you, Angie, for helping set this up and recording this. And I wish everybody a good weekend. Take care.